I am very happy to introduce Dr. Paul Dworkin, who is Executive Vice President for Child Health at Connecticut Children's Medical Center. He is the Director of the Help Me Grow National Center and Professor of Pediatrics at the University of Connecticut School of Medicine. His interests are at the interface among child development, child health services, and child health policy. Just what we need at this point. He has authored more than 175 publications in the fields of developmental behavioral pediatrics and general pediatrics. His vision led to the creation of Help Me Grow, a Connecticut statewide initiative to promote the early detection of children at risk for developmental and behavioral problems and their linkage to programs and services that is currently being replicated in over 20 states. Please join me in welcoming Dr. Dworkin.
Thank you, Darcy. Can you hear me? Yes? Good. Well, when my friend and colleague David Willis, a pediatrician who directs the Maternal and Child Health Bureau's home visiting program, asked if I might be available in his absence, and Darcia was nice enough to extend an invitation, I didn't quite appreciate the significance of going last after 3 days of researchers, scientists doing presentations on the basic science of child development. It's a little daunting, let me tell you, but I really, really am so pleased and honored to be here. And thank you all for staying for the culmination of this really very, very spectacular event. So I'm going to do as asked, and in fact, try to be the applied science portion of this 3-day conference. But first, I do want to bring you greetings from Hartford, the capital city of Connecticut, and from our Office for Community Child Health of Connecticut Children's Medical Center, a very innovative approach to trying to elevate the status of a children's hospital as a critical community resource. I'd love to talk about that, but I am not going to talk about that this afternoon. So I typically begin these talks, given that I am a pediatrician, with thinking about or talking about what our goal for child health services is. And rather than read this quote from our parent organization, the American Academy of Pediatrics, which I agree with, let me instead begin the way that I began a TED Talk about 1.5 years ago, and ask a question that I no longer believe is rhetorical. And the question is as follows: what if our goal for child health services was not merely to treat or even prevent childhood diseases and disorders, but was to promote children's optimal healthy development? And I suggest to you that if that is our goal, and I'd also suggest that it should be, it has profound implications for the way in which we deliver our services, design our programs, and build our systems. So over the next 30 minutes or so, I'm going to try to convince you of that point. And because you have been good enough to sit through 3 days of talks, and because you may have variable departure times and/or attention spans, let me share with you what my key message is, and I hope this makes even more sense about 30 minutes from now. That whether one views promoting children's optimal healthy development through the lens of child health, as I do, or through early life experiences or parenting practices, certainly themes that were emphasized over the course of these 3 days, the importance of cross-sector collaboration in early childhood comprehensive system building quickly emerges as a necessity. So I'm going to try to convince you of this, if you're not convinced already, by demonstrating the implications of the tremendous knowledge that we have, so much of which has been shared over the past 3 days, knowledge about early brain development and early child development. And then I'm going to take a few minutes to tell you a story of an intervention that we began as a pilot program in Hartford has now been disseminated across the state of Connecticut, and as we speak is being replicated in 24 states around the country. And what I will try to do through telling you this story is derive the implications for successful interventions. What are the critical concepts that we must bear in mind if our interventions to promote children's optimal healthy development are going to be successful? I don't have the complete answer to that. I don't think any of us do, but we have learned so much, and I'm going to try to share some of the critical implications with you. So for me, this story begins many, you can add a few more many years ago, really in the 1980s, when I began to think about child health services, the traditional content of those services, and whether or not certain components could be strengthened to promote children's optimal healthy development. And this slide depicts the standard traditional content of child health services. It has not changed very much from the 1970s and 1980s to today. These are the components. You may well be familiar with them, and in fact, these would be the components of the 2-month-old visit, was it this afternoon? Yes? Right, that our morning speaker left for. So I would suggest to you that if you look at this content, the specific components that have the greatest opportunity with respect to promoting children's optimal healthy development are the developmentally oriented counseling that we undertake during the visit, so-called anticipatory guidance, and are the process by which we identify children who are at developmental or behavioral risk. That is, developmental and behavioral monitoring, or what has been termed developmental and behavioral assessment, probably not quite correctly. So these are the two components that hold out the best opportunity to achieve our goal. And let me share with you some of the work that we've done in each of these. And keep in mind, this was the 1980s into the early 1990s. So first we looked at anticipatory guidance. And we asked the question, what if we brought to parents in a meaningful way the critical developmental themes in affective, cognitive, and physical development that really serve as the basis, as the underpinnings for the guidance and advice that we offer, so we could increase parents' understanding of their children's development. We did not propose to do this necessarily using terms like attachment, or synchrony, or autonomy and independence, or temperament. But what we did do was use those concepts to explain the basis for age-appropriate instructions that we would typically review at a health supervision visit. So we did a study, a case-controlled study, in which our control group received the usual counseling around general issues, and our intervention group received counseling that incorporated, embedded these critical developmental themes. And then we looked at a variety of outcome measures that actually were quite specific in terms of behaviors, parenting behaviors that we knew correlated with positive developmental outcomes. So positive maternal-infant interaction, maternal perceptions of infant temperament, family adaptation and adjustment, and satisfaction with the infant's behavior and development. Maternal satisfaction with the child health services that they received. And in fact, we found no difference between control group and intervention group. This posed a bit of a dilemma for us, because we did not want these results to be over or misinterpreted as saying anticipatory guidance is not worthwhile. That isn't what we studied. We looked at the value of routinely incorporating information about developmental stages and developmental themes. So we ultimately did publish this study, and here is how we offered recommendations. We suggested that anticipatory guidance should continue to be emphasized as a component of child health services, but that we needed to individualize the content and discuss issues at the level of parents' cognitive, cultural, and psychological readiness. And in fact, we advocated for an open-ended, parent-led agenda, beginning visits with the question, what's on your mind, what concerns might you have, and using that agenda setting to drive the counseling that went on during the session. And in fact, this is the tenor of recommendations that have currently been incorporated within our current guidelines for child health supervision, Bright Futures, published by the American Academy of Pediatrics with respect to anticipatory guidance. So we next shifted our attention, and again, this was the late 80s, to the process by which we identify young children with developmental and behavioral problems, so-called developmental screening. And at the time, I'm sorry that the Bowlbys left, because a shout out to England, I had the opportunity to participate in the British Working Party on Child Health Surveillance, which was an effort to look at the evidence and come up with an evidence-based, or at least evidence-informed approach to child health services. And I particularly was interested in this issue of developmental monitoring and how do we best identify children with developmental or behavioral delays or problems. And as I began to think about this issue, I realized there are standard criteria by which we judge conditions amenable to the screening process. And for us in child health, the prototype is newborn metabolic screening, which fits all of these criteria. I'm not going to read the criteria to you, except to point out, when you think about the types of developmental and behavioral issues that we are trying to identify through developmental screening, and consider the extent to which we are able to distinguish affected from non-affected persons, the extent to which the conditions must be treatable, the extent to which detection and treatment during the asymptomatic stage must yield benefits over later diagnosis and improve prognosis, and the extent to which resources are available, developmental and behavioral problems fall short. That's not to say that we should abandon screening, but they fall short by virtue of these criteria. Similarly, when we look at screening tools or tests, there are well-accepted criteria by which screening tests are judged appropriate for use. These are the criteria, and once again, if you look at our typical developmental or behavioral screening tools, while many of them have sound psychometric properties, they all fall somewhat short with regard to being ideal screening tools. They are not, by virtue of the conditions that they are trying to identify. On the other hand, we also conducted research that demonstrated the extraordinary importance, utility, and validity of parental appraisals and descriptions of their children's development. So we know, for example, that if parents have concerns about their child's development, particularly in areas like speech and language function, fine motor function, or cognition, that child is very, very likely to have a significant underlying developmental delay. Similarly, we know that parents' estimations of their children's development, compared to other children of the same age, how old would you say your child acts, are highly accurate and clinically important. And third, we know that parents report, contemporaneous reporting of their children's development tends to be very accurate if we ask the question the right way. Does your child use any of the following words? So our approach to developmental monitoring needs to be mindful of the limitations of screening tests and the importance of information available from parents. And we began advocating for a process that has been now termed developmental surveillance and screening. It is not surveillance or screening, and it is certainly not surveillance versus screening. It's a longitudinal process in concert with the periodic administration of screening tests. The longitudinal process includes the components of listening and attending to parents' opinions and concerns, obtaining a relevant developmental history, making observations of children longitudinally, identifying risk and resiliency factors, maintaining a record of the process, and particularly when concerns arise, sharing opinions with others who also are in a position to observe the child, the early care and education provider, the home visitor, and to periodically administer a more formal screening tool. At recommended ages, the American Academy of Pediatrics recommended ages are 9, 18, and 24 to 30 months of age. And the screening tool can be either a parent-completed questionnaire or a professionally administered tool, although the logistics associated with the latter are extremely problematic within the busy practice setting. So the process by which we can best identify children who are at risk for adverse developmental and behavioral outcomes is the process of developmental surveillance and screening. And as of 2006, the American Academy of Pediatrics adopted the process of surveillance and screening as their recommended approach to early detection. However, even in enhancing early detection, we recognized that this was necessary but not sufficient. Because if early detection doesn't lead to intervention, then it is not going to be helpful. And in fact, subsequently, one of our colleagues, a developmental behavioral pediatrician from Boston by the name of Ellen Perrin, noted that not only would the lack of intervention lack efficacy, but in fact, she considered early detection without intervention to be unethical. So keep in mind that all of this work was conducted in the 80s and the early 90s. And then we get to the 1990s, the so-called decade of the brain. And as you've heard through presentations over the past 3 days, our knowledge of early brain development, our knowledge of early child development really gained momentum and accelerated well prior to the 1990s. But what happened in the 90s was that it hit the press, the popular press and the professional press. And it began to have a much greater influence on the way in which we began to think about issues, and specifically the way in which we began to think about promoting children's optimal healthy development. So I am not, with this audience, going to review these basic concepts in early brain development. A number of you are far more knowledgeable about them than I am. But suffice it to say that these critical concepts in early brain development have profound implications for the way in which we go about our activities in support of promoting children's optimal healthy development. And I would suggest to you the fact that brain growth occurs disproportionately during the prenatal period and the earliest years of life, that neuroplasticity, while present across the lifespan, offers unique opportunities during earliest life, that there are critical periods of development in which obviously stimuli must be present in order for brain development to proceed normally, that development is sequential, therefore stimuli needed to be presented in a sequential manner. Few infants will benefit from an algebra lesson, few adolescents need to be held and rocked each day, although we all know some exceptions to that. And then the role of experience. And I just want to emphasize the extent to which these concepts can be brought to bear even with the lay public, and particularly with public officials who may not be schooled in the neurosciences. And we like to talk about the role of experience because we can so graphically illustrate what we are trying to say. And that is that the human brain has the ability and even the necessity to be shaped by experience. So we will point out that at birth, there are a mere 50 trillion synapses among neurons in the brain. And with the right experiences, at the right time, the number of synapses increases 20-fold by 1 year of age. And then with the right experiences, synaptic pruning, that is, the elimination of those synapses that are no longer important, enables the brain to achieve the efficiencies that support the highest level of our cognitive and related functioning. Policymakers get this, and the notion that experience is critically important in shaping the brain then becomes even more amenable to subsequent experiences, and round this goes, is a powerful message. So, given these critical concepts in early brain development, what are the implications as we think about interventions, as we think about our services, our programs, and our systems? And they're pretty obvious. In order to be effective, services must begin as early as possible. Stimulation during the first 3 years is particularly critical. It's not quite use it or lose it, but it's close. And services must be comprehensive, and they must be aligned with children's developmental stages and needs. So those were critical concepts in early brain development that really came forth in the 90s and are so important in encouraging and informing our thinking. Similarly, we've heard over the past 3 days, there are extraordinarily important concepts in child development that similarly should inform our thinking. And I'm just going to share one with you. Developmental trajectories has repeatedly come up. I want to share with you a way of framing developmental trajectories that has been articulated by a pediatrician, Neil Halfon, who's the director of the UCLA Center for Healthier Children, Families, and Communities. So what Neil talks about is children progressing along 3 developmental trajectories. There are those children who are progressing along a delayed or disordered trajectory. I'm a developmental behavioral pediatrician. These are my patients. Then there are children who, fortunately, the majority of whom are projecting along a healthy trajectory. And then there is a significant percentage of children, depending upon how you define it, at perhaps 15 to 20, 25% of children, higher among certain populations, who are progressing along an at-risk trajectory. These vulnerable at-risk children are those who tend to be invisible from the standpoint of our public policies, our programs, our services, and our interventions. And yet, as I will point out, this is where the greatest opportunity lies. So the notion of developmental trajectories, we also know, and this was mentioned this morning, that at any point in time, there are those factors that can have an adverse influence on children's developmental trajectories. And I just give you 3 examples: socioeconomic disparities, lack of access to health services, and domestic violence. So this could cause a child along the healthy trajectory to dip to the vulnerable at risk, or a child on the vulnerable at-risk trajectory to succumb to a delayed or disordered trajectory. And similarly, fortunately, you heard about these this morning, there are a variety of factors that can support children's optimal healthy development, promote so-called developmental buoyancy, and enable a vulnerable at-risk child to actually rise to a healthy trajectory. And you know what these are: protective home environments, quality early care and education, neighborhood safety and support, etc. This has profound implications for the way in which we think about service delivery and interventions. And I cannot improve upon a quote from a pediatrician, Robert Chamberlain, from back in 1992, so I am going to read this to you. The most effective long-term strategy appears to be the development of a comprehensive, coordinated, community-wide approach focused on preventing low and medium-risk families from becoming high risk, as well as, of course, providing intensive services to those who already have reached a high-risk status. 1992. This certainly bears repeating today. And in fact, what HALFON has also demonstrated is that if you look at our interventions for children with developmental or behavioral issues, concerns, problems, and look at the extent to which they are efficacious, that is, successful interventions, what he points out is that those interventions which are focused on vulnerable at-risk children are more efficacious than those interventions that are focused on disabled children. So watch which dots move. So the dots that move are those targeting vulnerable children. And this is just a simple schematic, but it really does speak to the efficacy of programs, lower intensity programs typically available at the community level that promote children's optimal healthy development, particularly those who are vulnerable and at risk. So if we're concerned with shifting the population curve, then this is the population that we need to be focused on. And then we have the ACE study, and I assume that most of you are familiar with the Adverse Childhood Experiences study, which also came forth in the 90s into the new millennium, which point out that the number of adverse experiences really do matter and that children are resilient, but these adverse experiences add up and ultimately correlate in a very, very strong way with terrible outcomes, whether one is thinking about physical health or mental health. So what are the implications of these concepts? Again, they're very, very profound. Treatment programs and services must be comprehensive, they must be multidisciplinary, and they must address the multiple factors that either facilitate or hinder children's optimal development. And as you'll see, we have really come to the conclusion that our interventions really need to focus on strengthening those protective factors that facilitate so-called developmental buoyancy. Services should address the needs of all children, recognizing that those with the greatest need will derive the greatest benefit. Our current policies that tend to focus exclusively on children with complex medical conditions, on children with the most significant developmental delays, are misguided. We also should be targeting vulnerable at-risk children. And yet, just within the past 1 to 2 decades, we have gone from having 20 states in this country who serve vulnerable and at-risk children through their Part C early intervention programs to 4 states in this country that serve vulnerable at-risk children. We're moving in the wrong direction. Okay, so with all of this by way of background, let me spend a couple of minutes sharing a story with you. And given that you are scientists and academicians, I felt a little bit defensive and the need to justify telling you a story. So I'm going to quote a cognitive neuroscientist who happens to be a professor emeritus from a nearby university as evidence. So Roger Schenck, in one of my favorite quotes, has said, "Humans are not ideally set up to understand logic. They are ideally set up to understand stories." And if there are cognitive scientists in the audience who disagree with this, don't disabuse me of it. I like it too much. Okay, so let me share with you, in ending, the story of how Help Me Grow evolved and the implications for interventions. So I showed you a photo of Hartford earlier on. Hartford is the state capital of Connecticut, the state with the highest per capita income in the country, and yet Hartford has been ranked the second poorest city of its size in the country behind Brownsville, Texas. Shame on us. Hartford has many of the urban ills that negatively impact children's healthy development, like, for example, lead poisoning. So in the 1990s, during the so-called Decade of the Brain, we had the opportunity, thanks to support from our local foundation, the Hartford Foundation for Public Giving, to gather together various constituencies. The specifics here don't matter, but we spoke with parents, we spoke with child health providers, we spoke with public officials, we spoke with policy advocates, we spoke with a variety of providers from early care and education and family support, and asked the question, what should we be doing to strengthen child health services to promote the best developmental outcomes for children? And it was amazing how quickly we came to 4 common assumptions, which we didn't recognize at the time is really the first step in achieving collective impact. So assumption number 1, and again, this was Hartford, poor Hartford. Children with developmental and behavioral problems were escaping early detection. There wasn't much doubt about that. Number 2, that even in relatively resource-poor Hartford, there existed a wide array of community-based programs and centers, family resource centers, parenting groups, et cetera, that were available and accessible to address children's developmental and behavioral needs and support families in promoting their children's optimal healthy development. That number 3, there was a gap between the best efforts of child health providers, early care and education, and family support providers to identify vulnerable at-risk children and the linkage of those children and their families to these community-based comprehensive programs and services. So our 4th assumption was that Hartford's children and families would benefit from a comprehensive, coordinated, integrated approach to early detection and linkage to services. And out of this came what ultimately we titled our Help Me Grow system with 4 critical components. The first, training child health providers, early care and education providers, family support providers, and parents in the process of early detection, that is developmental surveillance and screening. Secondly, community outreach to identify where those community-based programs and services are and to better understand what they are doing in support of promoting children's optimal healthy development. Third, a single portal of entry, a central portal of entry to access these programs and services. More about that in just a moment. And then 4th, because we knew there were gaps, we knew there were capacity issues, data collection to inform our advocacy as well as demonstrate that this program is efficacious. So this is an example of how Help Me Grow might work if a problem or concern is identified within the child health provider's office. So during a well-child visit, the pediatrician asks a parent if they have any concerns about their child's learning, behaving, or developing. The parent comes forward with a concern, and they are encouraged to contact, or the office can contact Help Me Grow through this central portal of entry. More about that in just a moment. The care coordinator identifies culturally appropriate, geographically appropriate programs and services, and then works with the parent to ensure successful linkage to those programs and services. The parent's connected to the resource, and the child health provider or whoever initiated the referral, with the parent's permission, is informed of the successful linkage. Child Development Info Line is really the central portal of entry in Connecticut, 1-800-505-7000. Operators are standing by and ready to take your call. It's open now. And these care coordinators are amazingly adept at engaging, establishing a relationship with parents, eliciting concerns, and identifying the key resources. And the other just unanticipated way in which Help Me Grow evolved in Connecticut is not only is it the central portal of entry for Help Me Grow to serve vulnerable at-risk children, but it has also become the central portal of entry for our Part C early intervention program, our Part B preschool special education program, and our Title V children with special health care needs program. So neither parents nor providers need to worry if they're calling the right place. The care coordinators can help sort out which is the most relevant program. Anybody interested in more information, by the way, I would invite you to check out the helpmegrownational.org website. I can't possibly do justice to this in just a few minutes. So we learned so much about advocacy around interventions. And let me just share with you three of a multitude of lessons that we have learned and has subsequently informed our advocacy on a whole host of issues. The first is the importance of the language that we use. If we went to our legislature or our executive branch and said we want to expand eligibility criteria for birth to 3 in Connecticut, which is our Part C program, that advocacy would have been dead on the legislative doorstep. No way. When we went and instead said we want to enhance children and families' access to community-based programs and services that are typically at no cost to the state, the family, or a managed care plan, our legislators and our governor were very interested. The importance of the language that we use. We've already talked about our focus on vulnerable at-risk children and a central portal of entry for programs and services. Not an exclusive portal of entry, but a central portal of entry that anyone could use. Secondly, the value of so-called strategic reframing. So when we designed Help Me Grow, we thought about it as a quote-unquote developmental program, right? It was focused on children who were vulnerable and at risk for poor developmental outcomes. Well, at the same time, our then governor, John Rowland, was very interested in expanding community-based resources for children with severe mental health problems. And we went to Governor Rowland and we said, we applaud your efforts with Connecticut Community Kid Care, but you need a primary or at least a secondary prevention strategy. And we knew through our data collection that the #1 reason why parents called Child Development Info Line was not developmental concerns. Speech and language concerns were the second most common reason. General developmental concerns were the third most common reason. The first most common reason were behavioral concerns. So we went to the governor. More importantly, we went to the head of the Office of Policy and Management, the chief budget officer, and said, we have a secondary prevention initiative that should be part of Connecticut Community Kid Care. We reframed Help Me Grow as a behavioral initiative. He put it in his budget, the legislature approved it, and it did, in fact, in 2002, become a statewide program in Connecticut. And then third, the need for data collection. And I mention this because skeptics said, yeah, you'll be successful with enhancing early detection, but you will not be successful in linking to programs and services because those programs and services don't exist. We said we think you're wrong. But we will collect data, and to the extent that there are gaps, to the extent that there are capacity issues, we will use that data to inform our advocacy, and our skeptics were okay with that. So how do we know that Help Me Grow is successful? Well, Connecticut, like many states, I don't know specifically about Indiana, is a results-based accountability state. That is, every program needs to be able to document what it's doing, how many lives it's impacting, and whether it is quote-unquote successful or not. Help Me Grow does this. So we know the number of thousands of children who are impacted each year. In fact, across our now 24 affiliates last year, when we tallied up, Help Me Grow touches over 1 million lives, children and their families. And we also know that a successful linkage is made 85% of the time. Very successful in terms of linking to a community-based program and service. And we also know that the health provider outreach piece has changed practice behavior. And as a pediatrician, I could tell you it's really hard to change our behavior. But we know that much more surveillance and screening and much more early detection is going on in child health providers' offices. But we wanted more. And I'm going to end, for those of you who are researchers, with asking you to share with me any thoughts that you may have that may strengthen our unique and what I think are innovative approaches to demonstrating efficacy and cost benefit. Because if you're not demonstrating both of these, you will not be able to sustain any successful intervention these days. So what we did from the standpoint of efficacy, we realized that to measure developmental outcomes would be futile. As one of the speakers emphasized this morning, There are so many influences on children's developmental outcomes that it's impossible to point to any one, even this broad an initiative, and say that's what has made the difference. On the other hand, we recognized the opportunity to identify proxies for developmental outcomes, that is, more proximate measures that, if we could show we were influencing, have sufficient research credibility to be able to say that we must be having a positive impact on developmental outcomes. And for this, we've partnered with the Center for the Study of Social Policy in Washington and really embraced the Strengthening Families Initiative and the Protective Factors framework. These 5 protective factors that you've heard about over the past 3 days: parental resilience, social connections, knowledge of parenting and child development, concrete support in times of need, and social and emotional competence of children. And we've been able to demonstrate through a multi-pronged study, this is just an example of the parent survey, that protective factors are strengthened as a consequence of linkage to community-based programs and services. Secondly, we recognized that we needed to be able to demonstrate cost-benefit, particularly if we were looking to engage states and the federal government in supporting this initiative. And we did this by demonstrating that when Help Me Grow and Child Development Infoline are available, pediatricians are less likely to refer children with behavioral concerns on to the next level of medical evaluation, either to a developmental behavioral pediatrician, a neurologist, or a child psychiatrist, which is not what the majority of these children need. What the majority of these children need is to be linked to a community-based program or service that is going to emphasize the parenting approaches that we heard about in the last hour that will ultimately make the difference. So we use data from Help Me Grow in Orange County, California, to show that if Help Me Grow were brought to scale nationally, this one change in practice behavior would save $53 million a year. That has been very helpful in our discussions with payors and particularly with Medicaid. So this is the current status of our Help Me Grow affiliate network. It's actually slightly out of date because Missouri just this week informed us of their interest in becoming an affiliate. Indiana is not to date. We'd certainly be interested in talking. And we are the Help Me Grow National Center. We provide technical assistance to states in replicating Help Me Grow, ensuring adherence to the core components and structural requirements that I mentioned earlier, as well as trying to inform the national discourse, including this focus on vulnerable at-risk children. The manner in which Help Me Grow is being sustained across the nation is through an embedding strategy. That is, I'll give you one example. The Maternal and Child Health Bureau gave West Virginia a home visiting grant, but said to West Virginia, you must build Help Me Grow to ensure the success of your home visitors in linking families to community-based programs and services. And as you can see by the myriad of federal initiatives into which Help Me Grow has been embedded, this is the answer to longer-term sustainability. So let me end by just sharing with you, just in bullet form, and again, I'd invite you to the website, some of the implications for successful interventions that we have now embraced and have promoted in a wide array of other initiatives designed to promote children's optimal healthy development. It's all about system change versus thinking about individual programs and services. There has to be cross-sector collaboration. If we say among child health, early care and education, and family support, that's much too narrow. We also must think about healthy homes and housing, transportation, workforce development, higher education, on and on and on the list goes. Third, we must focus on all children, as we've emphasized, especially those who are vulnerable and at risk. The benefits of a common portal of entry, easing access to programs and services for families, blending administrative and financial resources to make programs economically feasible and sustainable, linking to community-based programs and services that already exist and may need some expansion of their capacity, but do not need to be built from scratch. And then I've already talked about the critical importance of data collection, as well as the extraordinary work done by our care coordinators and the importance of care coordination in linking children and families to programs and services. And if I could just add one other piece of data, which was shocking to us. We found, I mentioned to you the 85% connect rate, families to programs and services, the number of contacts that it requires to achieve that level of success, an average of 7 contacts per family. Where does that care coordination capacity exist within our early intervention system? It doesn't. It needs to be built, and that's a major priority of our work right now. So in summary, I hope that within the allotted time, I've emphasized how our new knowledge of early brain and child development demands that we redefine the content and process of interventions to promote children's healthy development, and that interventions such as Help Me Grow are best viewed in the context of comprehensive systems supporting young children's healthy development. Thank you for your attention, especially given the lateness of the day and the hour. Thank you.
We'll take a couple questions. I have one for you to begin with. In 2011, the Surgeon General put out a report indicating that only 4% of hospitals in the USA are baby-friendly. A year later, there were 6% that were baby-friendly, and then they stopped reporting the percentage. And I don't see any inclusion of hospital birthing practices and rooming in practices. We saw on Friday night the movie The Milky Way, which compares our practices with those in Germany and Sweden, who actually pay attention to the research, and it seems like the hospitals are not paying attention.
Well, keep in mind here, I was talking specifically about a community-oriented initiative, but your point about hospitals is absolutely well taken, so I don't feel defensive about this at all. We were the first hospital in Connecticut to go baby-friendly a number of years ago, but hospitals need to change their approach, their mentality, and their orientation. The good news is that it is happening, even if it's happening for mercenary reasons. And what I mean by that is whatever health care reform ultimately brings, and I'm not going to get into that political discussion, there is uniform belief that ultimately organizations, institutions, hospitals will be bearing the risk, the financial risk for the populations that they are serving. So that ultimately there will be a flipping of the reimbursement scheme such that hospitals are paid X amount of dollars to take care of a population, and to the extent that they keep that population healthy, they will do well financially, and to the extent that they are doling out services and expensive procedures that in the past were well reimbursed, they will lose money. And the knowledge of that, the fear of that, is driving hospitals to think about what they should be doing at the community level. Now, that was not the impetus for our establishment of an Office for Community Child Health. It was much more to do the right thing and to recognize the lessons that we've learned here. But our office does include currently 13 community-oriented programs that include interventions around whether it's baby-friendly and promoting breastfeeding, whether it's injury prevention, whether it's HIV prevention, whether it's asthma management. I mean, a whole litany of programs that smoking cessation, tobacco exposure prevention, a whole litany of programs that that are analogous or similar to baby-friendly. More and more hospitals are now beginning to jump on this theme. And my feeling is, I don't care if they're doing it for the right or wrong reasons as long as they're doing it. But there was no financial incentive. In fact, there was a financial disincentive to go to baby-friendly because all of a sudden your major sponsors were now angry with you. And not that that's justification. So what I used Help Me Grow here as just an example there are a whole host of interventions that we need to be thinking about in a very comprehensive way if we're going to achieve the goal of promoting children's optimal healthy development. And certainly, breastfeeding is among them.
Thank you, Dr. Dworkin. I'd like to follow up on the question about baby-friendly. And I was thinking while you're talking about this that it's great that the focus is on children, but of course it encompasses and embraces parents in a lot of wonderful ways.
Yes.
But I was also thinking about the earlier time, the pregnancy and the birth, and certainly the information is there about baby-friendly practices and that those are best practices for mothers and babies. So who is responsible for making sure that people have that information?
Yeah, great.
You know, what do you think about that?
Right, right. No, your point's so well taken. And, you know, what I didn't specifically call out, but because of the theme of this conference, but what I equally well could have and perhaps should have is the whole lifespan approach, right? And obviously, and even if we call out the specific knowledge that we're garnering through the basic science of epigenetics, it has profound implications for what's going on prenatally and even earlier than prenatally. So who's responsible? You know, I think I don't know whether it's a glib answer or a profound answer, is we all are. So I'll give you just one little example of how we're trying to take this on. And I don't presume that we have all the answers. So we received a contract from the city of Hartford to develop its newest version of its blueprint for child health. We had been involved in this a number of years ago, and it kind of sat on a shelf. So we're a little reluctant to take this on. But we ultimately agreed to do it under two conditions. Number one, we didn't want to do a blueprint for child health. We wanted to do a blueprint for healthy child development, because that would be the type of systemic cross-sector collaboration that would really be required to make a difference. And secondly, we thought we couldn't look at children in isolation, and it really needed to be a blueprint for healthy maternal and child healthy development. And we're spending as much time trying to engage our colleagues on the prenatal side of the equation in identifying the interventions that make a difference. And there, I mean, you talk about home visiting during, I mean, the results, the impact is startling. It's stunning. And the fact that we are not making it universally available is, it's horrific, really. So that certainly will be a recommendation, as well as a number of the more specific interventions like the Baby Friendly Initiative. So thanks for mentioning that. You're absolutely right.